Good afternoon, my respected judges and the dignitaries present here. My topic is selective laser trabeculoplasty. Could it lead to corneal decompensation in the post-laser station? So as we know, management of chronic open-angle glaucoma remains a challenge for most of us because application of laser in these cases ushered a new era of non-invasive therapy with favorable patient compliance. SLT launched by 98 by Latina et al. And revolutionized the therapeutic benefit. Localized application of frequency-doubled AIOC laser for 3 nanoseconds results predictable trabecular photothermocolysis but does not spare corneal tissue also. Several studies done evaluating the efficacy of SLT, but corneal damages remain underscored. So why cornea is taken into account? Because the trabecular tissue being the target, it's most proximal to the endothelium. Endothelial injuries is not acceptable during SLT, but though unavoidable. We investigate the pre and post SLT corneas by the anterior segment OCT, to evaluate the effect of SLT on the corneal thickness. Literature says the corneal edema, haze, and thinning occurring within 24 to 48 hours post-laser. The aim of my study is to analyze the clinical biological profile of SLT and its roles modulating the corneal integrity, central corneal thickness, and endothelial cell count. It was a prospective interventional study done in a tertiary care eye center of Eastern India in between May 2017 to April 18. I included those cases who had a history of primary open-angle cases within the age group of 30 to 60, intraocular pressure not manageable by chronic topical medication, pseudoexfoliation, and pigmentary cases. Cases who had history of shallow angle, anterior synechiae, intumescent macular cataract, ocular inflammation, endothelial dysfunction with abnormal corneal size and shape were excluded. After including 31 cases, we have found that 21 cases were really had glaucoma. Informed consent taken and thorough ocular and systemic history taken, followed by onset, duration, progression of the disease specially inquired. Previous treatment modalities also asked and post-trap cases also identified. Baseline visual acuity slit lamp evaluation with the anterior segment and posterior segment by 78D done. Intraocular pressure by non-contact tonometry done. Indirect gonioscopy performed and speed classification system was used for documentation, followed by Humphrey BFA and pre-SLT endothelial count and anterior segment OCT imaging done. The SLT was performed by application of 1% pilocarpine in each eye, followed by laser performed in each 21 eyes. And Latina SLT gonio laser has been used to deliver the energy. The procedure was Q-switch AIOC laser with initial energies of 0.8 millijoule was used for 3 seconds to creating a 400 micron spot, followed by application of 1% brimonidine and moxifloxacin and dexamethasone drop for the last 3 days. This was the endothelial profile, and the first upper image is showing the pre and the lower image showing the post image, and the right we can see upper the pre and post image of the central corneal thickness. The result shows that 21 patients, from which 32 eyes subjected to laser, and among them 12 were male and 9 were female. The mean age of presentation was 48.7 and mean glaucoma medication was found 1.47. The mean number SLT laser shot application per eye was 156 and mean energy application 1.16 through the SLT in each eye. The mean total laser energy used 169 millijoule. And it has been found from the baseline, the mean intraocular pressure was 118.6, which is reduced to 9.12 after 1 month. The central corneal thickness found to be 538, which is a baseline value, which is reduced to 529 on 30 day. Mean endothelial cell count, which is reduced from baseline to day 7, but it is increasing to 2354 per millimeter square in day 30. So SLT has become a preferred modality for the open angle cases with poor compliances. SLT surpassed the drawback of ALT, being responsible for widespread tissue destruction and persistent inflammation. Besides the mechanical, cellular, and repopulation action, AIOC can alter the corneal architecture also. Though transient, but endothelial count and corneal thickness could undergo changes that deem troublesome for the patients. These nuances are temporary, but it bears immense importance to study the pathophysiological effect of SLT by advanced scientific understandings. The theories which is acting for the SLT, because mechanical theory which is postulated by Wise and Whiter, the cellular theory which is telling the stimulation of trabecular cells leading to removal of debris which is clogging the intertrabecular spaces, and repopulation theory. The exact mechanism of SLT remains elusive. General agreement that is resulted by increased aqueous outflow. The cornea is basically always a collateral victim because it is directly affected by the local AC reaction incited by the laser. Iritis and cyclitis are common that can lead to corneal shrinkage, as published by Latina et al. In 2006. Tanaka T et al. Postulated the theory of lamellar dysregulation and trivial injury, which was published in 2003 in Survey Ophthalmology Journal. corneal stroma in response to thermal coagulation, subsequently followed by replenishing of keratocytes, which are treated the area during healing process. So to conclude, I can say that transient changes in the corneal endothelial cell count of the corneal thickening after a single session of SLT occurs. ECC appears reduced by 5% at the 1 week after SLT, which is gradually increased to baseline after 1 month. Central corneal thickness transiently reduced 1% at 1 week after SLT with gradual increase to baseline level by 1 month. Falsely low IOP reading may be resulted from altered corneal physiology. Thank you, sir.